Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important session. We are going to continue our exam slide rapid revision series part 8, and we are back with very important slides. So please pay a lot of attention. Okay. So the case number 71. Okay. So what we can see over here is a 43-year female with asymptomatic hypercalcemia. So what you can appreciate over here is a well circumscribed tumor, okay, which is showing a compressed normal parathyroid gland, okay, the cells of which are quite small as compared to the tumor cells. Okay, now if you look at the arrangement of the tumor cells, so they are growing in the form of solid islands as well as they are growing in the form of cord, as you can appreciate. Okay, so they are growing in the form of cord as well as they are growing in the form of follicles as well as they are growing in the form of microcyst, and there is an admixture of tumor cells, meaning so individual tumor cells, you can see the polygonal tumor cells, okay, with pale to eosinophilic cytoplasm. So these are the chief cells. Then you can see the oxyphil or the oncocytic group of cells over here, okay, which is having eosinophilic cytoplasm, and also you can see certain clear cells, okay, over here. And very importantly, what you can appreciate over here, that the cell membrane is quite distinct, okay, very well demarcated cell membrane is there. So quite distinct cell membrane can be appreciated. So what is this? Is the case of a parathyroid adenoma. So what we can appreciate, section shows a well circumscribed tumor mass with a rim of normal parathyroid gland in the periphery. The tumor cells are arranged in the form of solid sheet, cords, follicles and microcyst traversed by delicate fibrovascular septa. There is an admixture of the chief cells, which is polygonal with pale eosinophilic cytoplasm, clear cells with clear cytoplasm, and oncocytic or oxyphil cells with deep eosinophilic cytoplasm, and all of them, they have a very well defined cell membrane. The nucleus is round, uniform and centrally located. There are areas of fibrosis and hemorrhage, and stroma shows no adipose tissue, and there is no necrosis or increased mitotic figures noted. Okay, so it's the case of parathyroid adenoma. So parathyroid adenomas, they have well circumscribed borders or occasionally be surrounded by thin fibrous pseudocapsule. The tumor is hypercellular, but stromal fat is usually absent or sparse. So this is in this is in contrast to the normal parathyroid, which is having good amount of stromal fat. Okay, so in case of your hyperplasia or in case of adenoma, in both conditions the stromal fat is scanty. A thin rim of normal or compressed parathyroid gland can be identified on the outer aspect of the adenoma, as we can appreciate. So this thin rim is basically pointing towards an adenoma. It is not present in hyperplasia. Remember this point. Okay, so this is pointing towards adenoma. The growth pattern is diffuse, but there can be vague nodular or lobular pattern, or even more rarely a multinodular pattern. A delicate vascular network taking the form of thin fibrovascular septa traverses the tumor. The tumor can be arranged in the form of solid sheets, cords, acini, follicles as well as microcysts. So we have shown that in the same tumor, even in the same field, we can see different patterns which are existing together. Okay. Most parathyroid adenomas are composed predominantly of chief cells, which are polygonal cells with round nucleus, scan to moderate amount of pale eosinophilic cytoplasm, often mixed with the oncocytic or oxyphil cells, as well as there are clear cells. Oncocytic parathyroid adenomas account for about 3 to 6% of parathyroid adenomas, and water clear cell parathyroid adenomas, they are uncommon. Now chief cells, if you see, they are polygonal with clear or slightly eosinophilic cytoplasm. The nucleus are lymphocyte like and centrally located and have well defined cell membranes. The nucleus may show significant enlargement, hyperchromasia or pleomorphism. Occasional mitotic figures can be identified, but it is less than 5 per 10 millimeter square. So coming to the important viva questions. Classify the tumors arising from the parathyroid. So they are parathyroid hyperplasia, parathyroid adenoma, parathyroid lipoadenoma, atypical parathyroid tumor and parathyroid carcinoma. So discuss the salient changes in the current WHO 5th edition with regards to the tumor which is arising from the parathyroid. So in this current WHO 5th edition, for the first time, parathyroid hyperplasia has been discussed. Secondary hyperplasia represents the only true parathyroid hyperplasia. Despite the historical use of the term hyperplasia for men syndrome, hyperparathyroidism in this syndrome is almost always due to multiglandular or multinodular adenoma. For this reason, these are discussed in the section of parathyroid adenoma. Now remember, previously whatever parathyroid lesions were encountered in men's syndrome, we used to call them as hyperplasia or hyperplastic lesion, but currently it is known that they are not hyperplastic lesion, they are rather multiglandular or multinodular adenomas. Okay. Parathyroid lipoadenoma is now discussed as an individual entity, unlike in the previous edition where it was included as a variant of parathyroid adenoma. The general rule is that more than 50% of the volume of the gland should be adipose tissue to warrant the diagnosis of lipoadenoma. The term atypical parathyroid tumor, defined as a parathyroid neoplasm of uncertain malignant potential that demonstrate atypical cytological and architectural features but lacks unequivocal features of malignancy, that is invasion and metastasis, is introduced to replace the previous term which was atypical parathyroid adenoma. So this term adenoma has been replaced with the term tumor. So discuss the histopathological features of parathyroid adenoma we have already discussed. Okay. When is the term oncocytic parathyroid adenoma used? So when the oncocytic cells constitute more than 75% of the adenoma, it is termed oncocytic or auxophyll parathyroid adenoma. Now discuss the molecular genetics of parathyroid adenoma. So for the sporadic, so there are both sporadic cases as well as familial cases. So for the sporadic cases, remember cyclin D1 gene alterations are there, leading to overexpression of cyclin D1 protein. MEN1 mutations, okay, in sporadic parathyroid adenomas, most frequent somatic alterations are loss of heterozygosity of 11q13 seen in 35% cases and biallelic MEN1 inactivation seen in 20% of the cases. CDC73, which encodes a protein that is parafibromin involved in transcriptional regulation, is mutated in 70% cases of parathyroid carcinomas, not in adenomas. So clearly CDC73 mutation is basically affecting sporadic parathyroid carcinomas and very occasionally they are involving adenomas. So remember this point, only occasionally they will involve adenomas, okay, but more commonly this mutation is present in parathyroid carcinoma. Then comes the familial cases. The genetic susceptibility is there. So familial syndromes are a distant second to sporadic parathyroid adenomas as causes of primary hyperparathyroidism. The genetic syndromes associated with familial parathyroid adenomas include MEN1 syndrome, MEN2 or 3 syndrome affecting the RET oncogene, MEN4 affecting CDKN1B, and hyperparathyroid jaw tumor HPT-JT syndrome affecting CDC73 gene. Okay. Now, what are the subtypes of parathyroid adenoma? We are having two main subtypes. One is the oncocytic or auxophyll variety, another is the water clear cell variety of parathyroid adenoma. What is the most common site of parathyroid adenoma? It arises in the parathyroid gland, with the inferior glands affected slightly more frequently than the superior glands. Parathyroid adenomas can also occur in supernumerary parathyroid tissue or in ectopic regions. Okay, ectopic regions where you have ectopic parathyroid like in the thyroid gland, thymus, retroesophageal area, mediastinum, vagus nerve, carotid sheath, etc. Now discuss the immunohistochemistry of parathyroid adenoma. The tumor cells are positive for cytokeratin, pan-neuroendocrine markers like chromogranin synaptophysin is positive, parathormone PTH and GATA3 positivity is there. Now remember one thing, many a times the parathyroid can be present, the parathyroid adenoma or the parathyroid gland itself is present inside the thyroid gland. Okay, so in that case and in situation where predominantly the parathyroid adenoma is having a follicular arrangement, in that case you might mistake it for follicular adenoma. So in that condition you can go for the IHC. So remember, in parathyroid adenoma, thyroglobulin, TTF1 and monoclonal Paxil stains are negative. The vast majority of sporadic parathyroid adenomas, they show retained nuclear parafibromin expression. This is completely lost in case of parathyroid carcinoma. Remember, parafibromin expression is lost in case of parathyroid carcinoma because they are having CDC73 mutation. Because of this mutation, it is lost. Morphological clues to the tumors which are associated with CDC73 mutation termed parafibromin deficient parathyroid tumors include eosinophilic cytoplasm with perinuclear clearing, nuclear enlargement, microcystic change and a sheet-like growth pattern. Most commonly they are present in case of carcinomas rather than in adenomas. Now discuss the differential diagnosis of parathyroid adenoma. So it includes parathyroid hyperplasia, parathyroid carcinoma, normal parathyroid, thyroid follicular adenoma and paraganglioma. Now very important, whenever a parathyroid gland, a parathyroid exam slide will be there 100%. So the most important question that the examiner will ask you is to differentiate between a normal parathyroid gland versus an adenoma versus hyperplasia versus carcinoma. This is very important. Okay. So parathyroid adenoma versus hyperplasia. How do you differentiate? Hyperplasia, parathyroid hyperplasia usually involves all the 4 parathyroid glands, while adenomas usually involve one gland. A thin rim of normal or compressed parathyroid gland can often be identified on the outer aspect of an adenoma, and as many as 15% of the patients, they have double adenomas which involve superior parathyroid glands mainly. So this is how you differentiate between an adenoma versus hyperplasia. How do you differentiate adenoma versus normal parathyroid gland? Now remember, the normal parathyroid gland will show the presence of adipocytes along with the parenchymal cells, whereas both the hyperplastic tissue, hyperplasia as well as adenoma, they are showing scant amount of adipose tissue. A normal gland measures up to 6 to 8 millimeters and weighs up to 40 to 60 milligram, whereas an adenoma usually weighs around less than 1 gram. Mean weight is 0.55 gram, and the size ranges from less than 1 centimeters to several centimeters. Okay. Now versus carcinoma, remember, parathyroid carcinoma, for the diagnosis of that, it has to demonstrate unequivocal invasion, has to be there. Okay, that is signs, symptoms of metastasis, distant or local recurrence or angioinvasion. All these things has to be there for diagnosis of a carcinoma. Then how do you differentiate from paraganglioma? Paraganglioma, they show nested growth wrapped by sustentacular cells with increased vascularity, and these sustentacular cells, they are positive for S100. And remember, the paraganglioma cells, they are negative for parathormone, PTH. Thyroid follicular adenoma, as I already explained. So this confusion can occur when the parathyroid tumor is located inside the thyroid gland and a follicular growth pattern is present. So in that case, do IHC. So as I said, thyroglobulin, TTF1, monoclonal Paxil stains, they are negative in case of parathyroid adenomas. Okay. Now discuss the prognosis of parathyroid adenoma. Parathyroid adenomas, they are benign lesions. Recurrent hyperparathyroidism develops in less than 2% of the patients, and in the setting of multiglandular disease, the prognosis is dependent on the underlying clinical or genetic syndrome. Okay, so this is about a case number 71, which was parathyroid adenoma. Now coming to the second case, the case number 72. So we can see an infiltrative tumor mass over here. So first, what is the history? Let us look at the history. It is a 56-year male who is presenting with nephrolithiasis. So there is a renal disease along with bone pain. So there is a simultaneous renal and bone disease is there. Along with that, the serum calcium level is 15.8 milligram per deciliter. So it is very high. It is approximately 3 to 4 milligram, per deciliter, which is more than the normal calcium level. So it is a case of a hyperparathyroidism and with very high calcium levels, and a simultaneous bone and a renal disease is there. If you look at the morphological feature, you can see an infiltrative tumor, okay, wherein the tumor has been divided by the fibrous bands over here. Okay, this has been, divided by the fibrous bands. Okay, and this individual tumor islands, if you see, they are basically having a diffuse or solid pattern of growth, wherein the individual tumor cells, they are, very much similar to the one we see in parathyroid adenoma. So individual tumor cells are like that, and they are separated by fibrovascular septa. But one very important aspect that you will see over here, that this basically they are invading the nearby soft tissue. So much so you can see that the tumor islands, okay, they have invaded the nearby soft tissues and they are growing in between the skeletal muscles. Not only that, you can see a tumor plug which is filling in a vessel, okay, a tumor plug filling in a blood vessel, and also it is associated with a thrombus, okay, this tumor plug. So this is the vascular invasion that we can see. So what is the diagnosis? It is a case of a parathyroid carcinoma. It is a case of parathyroid carcinoma. It is very commonly asked. Now, although parathyroid carcinoma is never asked in the exam directly, what will be asked to you is a parathyroid adenoma. Very commonly it is asked. But we are discussing this slide because whenever you are asked a slide on parathyroid adenoma, all the questions relating to parathyroid carcinoma will also be asked to you. So that is why we are discussing this case. So section shows an infiltrative tumor mass divided by broad fibrous bands, giving a multinodular appearance, as we can appreciate over here. The tumor shows obvious invasion into the surrounding soft tissues, as we have seen the smooth contoured islands of the tumor invading the skeletal muscle, as we have appreciated over here very carefully. Then the tumor islands comprises of solid sheets of tumor cells traversed by fibrovascular septa, and the individual tumor cells are very much like what you have seen in the adenoma. They are polygonal. Chief cells are there with coarse chromatin, prominent macronucleoli. and moderately abundant pale to eosinophilic cytoplasm. Mitotic figures are prominent along with areas of coagulative necrosis, and there is a tumor plug filling the lumen of the blood vessel outside the main tumor mass. So there is a vascular invasion. So what is the important histopathological features of carcinoma? The tumor is variably cellular and often subdivided by broad bands of fibrous septa extending from the pseudocapsule. The fibrous bands are present in most parathyroid carcinoma. However, their presence alone is not diagnostic of malignancy. The cytoarchitectural features are generally similar to those of parathyroid adenoma, with polygonal cells arranged in diffuse solid sheets, trabeculae and packets, but follicles are practically never formed. The nuclei are either uniform or pleomorphic, but nuclear pleomorphism by itself is not diagnostic of malignancy, since it can also occur in adenoma or hyperplasia. Nucleoli are prominent. You will see macronucleoli in approximately 50% of the cases. The cells have clear or eosinophilic cytoplasm, and occasional cases are composed exclusively of oxyphil cells. Coagulative necrosis is seen in some cases. Cytological atypia can be quite variable, ranging from tumors showing marked pleomorphism with coarse chromatin and prominent macronuclei, while others are deceptively bland looking, mimicking benign counterparts except for the presence of invasive growth. So for diagnosis, only cytological atypia cannot be relied on. So for diagnosis of parathyroid carcinoma, it is must that you are having an unequivocal invasion. Vascular, capsular, perineural invasion has to be there. Lymphatic invasion is there. Local distant metastasis should be present. Either of these things has to be present. Okay. What is atypical parathyroid tumor and what is the update regarding the same? So as I've already told in the previous discussion only, so atypical parathyroid tumor is a parathyroid neoplasm that demonstrates atypical cytological and architectural feature but lacks unequivocal capsular, vascular or perineural invasion or invasion into the adjacent structures of metastasis. Okay. So the term atypical parathyroid tumor, if you see, is introduced to replace the previous term which was atypical parathyroid adenoma. So this is the only change. Second, what is the morphological triad of malignancy which is seen in parathyroid carcinoma? It is coagulative necrosis in association with increased mitotic activity, that is more than 5 mitosis per 10 millimeter square, and even the presence of a single atypical mitosis is suggestive of malignancy. Along with that, the presence of prominent macronucleoli. So this is the morphological triad of malignancy for parathyroid carcinoma. What are some of the important clinical and laboratory findings favoring the diagnosis of parathyroid carcinoma? So very severe hypercalcemia, okay, approximately 3 to 4 milligram per deciliter above the higher normal levels, okay, higher limit of normal levels. Then third or second generation PTH assay ratio above 1, okay. Simultaneous presence of renal and bone disease, as we have already seen, okay, in the history, that the patient was presenting with nephrolithiasis along with the bone pain. So if both things are present simultaneously. Lastly, the presence of a palpable mass in the neck. Symptomatic hyperparathyroidism is associated with a palpable neck mass, often more than 3 centimeters, which requires, in that case, it requires exclusion of parathyroid carcinoma. So discuss the classical HP features of parathyroid carcinoma. We have already discussed. Define different types of hyperparathyroidism along with examples. So this will also be commonly asked whether you get an adenoma or a carcinoma slide. So hyperparathyroidism is caused by elevated parathormones PTH level and is classified into primary, secondary and tertiary. So primary hyperparathyroidism is characterized by an autonomous overproduction of PTH, usually resulting from an adenoma or hyperplasia of parathyroid tissue. The frequency of the various parathyroid lesions underlying hyperfunction includes, so adenoma constitutes 85 to 95% of the causes of primary hyperparathyroidism. Then primary hyperplasia, diffuse or nodular variety, accounting for 5 to 10% of the cases of primary hyperparathyroidism, and parathyroid carcinoma constituting only 1% of the cases of primary hyperparathyroidism. So primary hyperparathyroidism, it is usually a disease of adults and is more common in females than males by a ratio of nearly 4:1. Then comes secondary hyperparathyroidism. There is a compensatory hypersecretion of PTH, usually in response to chronic renal failure or vitamin D deficiency or malabsorption. Then we are having tertiary hyperparathyroidism, where there is a persistent hypersecretion of PTH, representing autonomous PTH production that usually develops after long-standing secondary hyperparathyroidism. Okay, so this is your 3 types of hyperparathyroidism along with examples. Now discuss the molecular genetics of parathyroid carcinoma. So what are the molecular genetics? Let us see when parathyroid carcinoma arise in the setting of HPT-JT, that is hyperparathyroidism jaw tumor syndrome. Inactivating germline mutations or deletions of CDC73 are found in majority of the family members. Okay. Moreover, 40 to 80% of sporadic parathyroid carcinomas also harbor inactivating CDC73 mutations, in addition to frequent loss of heterozygosity of CDC73 locus at chromosome 1q. Other reported genomic alterations in sporadic parathyroid carcinomas include loss of TP53 and RB1 allele, although mutation in these genes are rarely found. Amplifications of CCND1, amplification of your CCND1, if you see, encoding cyclin D1 is present in a subset of cases. Unlike in parathyroid adenoma, MEN1 mutation are only rarely reported in parathyroid carcinoma. TERT promoter mutations are also rarely reported in parathyroid carcinoma, and epigenetic alterations are also present. Okay, so this is the molecular genetics of parathyroid carcinoma. Now, what is parathyromatosis? Very commonly asked question in the exam. It is defined as local recurrence throughout the neck and or mediastinum due to mechanical displacement or hyperplasia of rest of parathyroid tissue. Parathyromatosis may show fibrosis and pseudo-invasion of fat in a buckshot pattern that can be impossible to distinguish from parathyroid carcinoma without the history of hyperplasia and close clinico-pathological correlation. Now, discuss the differential diagnosis of parathyroid carcinoma. Number one is parathyromatosis, as we have already said. Parathyroid adenoma, atypical parathyroid tumor, they will not have any sign symptom, means they are having cytological atypia, but they are not having clear-cut signs of invasion. Parathyroid adenoma, we have already discussed how to differentiate again between both of them. The thing is, invasion is absent in case of adenoma. Then we are having well differentiated thyroid carcinoma, differentiated high grade thyroid carcinoma, poorly differentiated thyroid carcinoma, medullary thyroid carcinoma. Then third important is paraganglioma, metastatic neuroendocrine tumors, post biopsy reactive changes, secondary or tertiary parathyroid hyperplasia with increased proliferative activity and fibrosis. So the details of differential diagnosis is present in the individual lecture, so you can go and refer to them. So right now we are just enumerating the important differential diagnosis of parathyroid carcinoma. So what is the IHC profile of parathyroid carcinoma? So unlike parathyroid adenomas, carcinomas are associated with immunohistochemical loss of expression of parafibromin, APC, E-cadherin, P27, BCL2, MDM2 and 5-hydroxymethylcytosine. Carcinomas, in comparison to adenomas, they will show positivity for PGP 9.5, galactin 3 and TERT, as well as P53 overexpression, and an increased Ki67 labeling index, often more than 5%. Among these, remember, loss of nuclear parafibromin expression has been regarded as a reliable biomarker of malignancy. 50 to 70% of all parathyroid carcinomas lack staining for parafibromin. Positivity for PTH and GATA3 can be used to confirm parathyroid origin. So what is the prognosis of parathyroid carcinoma? Estimated 5-year and 10-year overall survival rates are 78 to 85% and 49 to 70% respectively, according to WHO 5th edition. Loco-regional and or distant metastasis, example to the lung, liver, bone, occurs in 25 to 60% cases of parathyroid carcinoma. Now, what are the morphological features of CDC73 mutated parathyroid carcinoma? So, CDC73 mutated parathyroid carcinoma, commonly they have eosinophilic cytoplasm with perinuclear clearing, larger tumors with encapsulation, diffuse sheet-like growth, nuclear enlargement, arborizing vasculature and microcystic change, as well as a high proliferative rate. Okay. What is the most important diagnostic criteria for the diagnosis of malignancy? So this is given by the WHO. So for diagnosis of parathyroid carcinoma, at least one of the following has to be there. Number one, angioinvasion, that is vascular invasion, typically assessed at the tumor periphery or at the tumor capsule but not within the tumor. Lymphatic invasion, perineural invasion, local malignant invasion into adjacent structures or organs, or histologically documented regional or distant metastasis. Okay. So with this, we have completed the case number 72. Now we are going to go into the case number 73. So if you look at the case number 73, we see a 42-year male presenting with headache, sweating and palpitation, and on examination the blood pressure is 160 by 110 millimeter mercury, that is they are presenting with hypertension, and these are signs symptoms of hypertension. So what we can appreciate over here is a well circumscribed tumor wherein the tumors are arranged in the form of nest and alveoli in a Zell-Bolin pattern, and they are divided and they are supplied and divided by a very rich fibrovascular network or a very delicate and rich supply of delicate vasculature is there. In the high power view, what you can appreciate that you are having individual cells, they are polygonal with moderately abundant basophilic to amphiphilic cytoplasm, and they are granular, which is actually containing, these are basically the granules which are containing catecholamines. Okay, over here one mitotic figure also you can appreciate. Over here the nucleus is uniform, basically bland, not very not pleomorphic at all, as you can appreciate over here. And therefore, what is this case? This is the classical case of a pheochromocytoma. It shows a well circumscribed tumor mass arranged in the form of small nest